like hospital. We are doing it with some very senior legends of dermatology. So in Karachi and covering the whole region of Sindh, myself being the office bearer. So we are covering and representing the province of Sindh here. So today the teaching institute is our Khan University Hospital. So the CPC provides a unique platform to bridge the clinical and pathological aspects of patient care, sharpening our diagnostic skills and fostering multidisciplinary collaboration. By engaging with cases presented here, we deepen our understanding and strengthen our collective expertise. So I encourage everyone to actively participate as your insights are crucial to making this discussion both productive and impactful. So let's make this a truly interactive and rewarding academic experience for all. So I shall first of all now begin with case one. So our resident, Dr. Zainab, is going to present it. So over to you now.
Thank you, ma'am. Assalamu alaikum, everyone. I am Dr. Zainab, PG Year 3 at Aga Khan University Hospital, and I'm going to discuss the first case of CPC. My case is a 37-year-old male who is a resident of Karachi, known case of psoriasis since the age of 17 years, and known case of psoriatic arthritis since 2018. He presented to our clinic with a complaint of non-healing ulcer on left thigh for last 2 months. According to my patient, he was all right 8 months ago when he first noticed a pustule on his thigh. It was associated with extreme pain. The lesion did not respond to any of the treatments that he tried. He consulted multiple general practitioners and was prescribed topical and oral antibiotics. But despite the treatment, the lesion did not respond and progressed to form a non-healing ulcer in the following months. And with this complaint, he came to our OPD. There was no history of any similar lesions elsewhere in the body. There was no history of any swelling of the affected limb. There was no history of lumps or bumps. His systemic review revealed history of arthralgias, early morning joint stiffness, fatigue, and body aches. Rest of the systemic review was unremarkable. In his past medical and surgical history, there was history of recurrent flares of psoriasis, for which he was prescribed methotrexate at multiple occasions, but the patient used it erratically in last 12 years. The initial dose prescribed was 7.5 mg per week, and a maximum dose of 20 mg per week was given on one instance for a period of 1 month. The cumulative dose was approximately 870 mg. He was also using topical steroids and topical vitamin D analogs for his psoriasis. Rest of the past medical and surgical history was unremarkable. In his personal history, his quality of life was normal. His sleep and appetite and bowel habits were all normal. There was no history of any weight loss. He was a smoker with 5-pack year history. He belonged to an upper middle class family and was engineer by profession. In his family history, there was no history of psoriasis or any other skin disorder, and no history of any skin malignancies in the family. He was using adalimumab for his psoriatic arthritis since May 2023. It was started at a loading dose of 80 mg subcutaneous injection, followed by 40 mg twice monthly subcutaneous injection. He was also using topical treatment for psoriatic lesions. On examination, he was a young male of average build, well-oriented to time, place, and person. His vitals were normal. There was no palpable cervical, axillary, and inguinal lymph nodes. There was no jaundice, anemia, or clubbing. His hair and mucosae were normal. There were no nail changes. PASI at the time of presentation was 0.6. On further cutaneous examination, there was a single well-defined round ulcerated plaque located on the left anteroposterior aspect of the left thigh. measuring around 1.5 into 1.5 centimeter. The ulcer had undermined edges and violaceous border, floored with purulent discharge and granulation tissue. The surrounding skin was mildly erythematous. It was extremely tender to touch. This is the pictorial representation of evolution of lesion from April to July 2024 when he presented to us. His systemic examination was unremarkable. His motor and sensory systems were intact. Now, based on the history I have told and the clinical pictures I have shown, which differential diagnosis come in your mind? You can use the chat box for that. Okay, so several people have shared pyoderma gangrenosum as their differential. So our provisional diagnosis was also pyoderma gangrenosum, considering the presentation. Our other differential diagnoses included lupus vulgaris, cutaneous leishmaniasis, non-tuberculous mycobacterial infection, squamous cell carcinoma, and deep mycosis. His blood investigations revealed hemoglobin of 15.1, TLC of 5.6, platelet count was 271. His ESR and CRP were normal. His renal function test, liver function test, and urine DR were all in normal range. Skin punch biopsy was advised, which revealed hyperkeratosis, keratin pearls, atypical squamous cell proliferation, and lymphocytes in the dermis. It was at this point that he was referred to plastic surgery for excisional biopsy, which revealed well-differentiated squamous cell carcinoma with deep margins 1.5 centimeter away, and depth of the invasion was 0.6 centimeter. There was no lymphovascular involvement and no perineural involvement. So our final diagnosis was squamous cell carcinoma. So for management, he was referred to plastic surgery where excision of his lesion was done with 10 millimeter marginal clearance followed by local flap coverage. Oral antibiotics were given according to the culture and sensitivity report, which yielded methicillin-sensitive Staph aureus. Skin surveillance was advised. This is the picture when the lesion was excised. And now in the picture on right is immediate post-op picture. And this picture was taken at 50th post-op day. So he did develop a seroma in between. That's why the small defect was present at 50th day. He was referred to oncologists who recommended 4 monthly follow-up for first year and then 6 monthly follow-up for second year, which will include physical examination and ultrasound to rule out any lymphadenopathy. I would like to add here that he did get an ultrasound, it was normal. Now to summarize my case, it was a young male, known case of psoriasis and psoriatic arthritis, who was on biologics, who presented to us with painful non-healing ulcer on the thigh for 2 months. Biopsy was advised with the provisional diagnosis of pyoderma gangrenosum. However, the biopsy revealed squamous cell carcinoma. A collaborative care plan was made, which involved plastic surgery, where excision followed by flap coverage was done. Rheumatology was taken on board for consideration of switching adalimumab to another drug. Oncology advised surveillance to the patient for 2 years. Now discussion and literature review. So squamous cell carcinoma is a malignant tumor arising from epidermal keratinocytes or its appendages. It is the second commonest skin cancer after basal cell carcinoma. The incidence of squamous cell carcinoma increases with age. Mostly squamous cell carcinoma develops on the photodamaged skin of the head and neck. And the risk factors that are associated with squamous cell carcinoma include male gender, human papilloma virus infection, Fitzpatrick skin type 1 and skin type 2. Its incidence is very low in Fitzpatrick type 4 to 6, which is around 2.23%, and also very less documented in literature. So whenever there's a diagnostic doubt, a skin biopsy is the standard technique to establish the diagnosis of squamous cell carcinoma. Squamous cell carcinoma is classified into low risk and high risk and very high risk group. The people who are immunocompetent and those with lesion less than 2 centimeter are classified under low risk group, while those who are immunosuppressed or on biological therapies are classified under the category of high risk and very high risk squamous cell carcinoma. A retrospective analysis of the drugs associated with the development of cutaneous squamous cell carcinoma, as reported by patients on the FDA's adverse event reporting system, was done between the year 1997 to 2023, and a total of 4,792 cases of squamous cell carcinoma as an adverse effect were reported. According to this study, these are the top 20 medications that cause squamous cell carcinoma, where lenalidomide was the leading cause of the squamous cell carcinoma as an adverse effect, followed by tacrolimus, and number third by adalimumab. 363 cases were reported. 363 cases of squamous cell carcinoma were reported with adalimumab use. This is another case report where a 64-year-old male who was a known case of hidradenitis suppurativa was using adalimumab for 2 years, and he presented with a rapidly growing tumor in the buttocks, which came out to be squamous cell carcinoma. Adalimumab is a TNF-alpha inhibitor. TNF-alpha in our body promotes tumor-infiltrating dendritic cells, which triggers potent immune responses, and this causes tumor rejection and long-lasting immunity. While the TNF-alpha antibodies, they block these anti-tumor immune responses and promote the growth of immunogenic tumors. Adalimumab is associated with squamous cell carcinoma. The incidence is as low as less than 0.06%, and the average time of onset of cutaneous squamous cell carcinoma from the use of adalimumab is 11 months. This study was done in Danish population where association of use of methotrexate with the skin cancer was studied. And it was found that methotrexate was associated with an increased risk of BCC, cutaneous SCC, and cutaneous malignant melanomas. However, cutaneous squamous cell carcinoma was associated with a higher cumulative dose of methotrexate, which according to this study was equal to or greater than 2.5 gram. Here I would like to tell that our patient was taking methotrexate, but the cumulative dose was less than 1 gram. Also, this study was done in Danish population where skin type is 1 to 3. So again, in contrasting to this study, our patient belonged to the skin type 4 to 6. And also, during the treatment, he did not complain of any lumps or bumps or any lesions. When he developed this lesion, he was already on adalimumab for 8 months. So this makes methotrexate a less plausible cause for squamous cell carcinoma in our patient. So the take-home message from this presentation is that we should have high index of malignancy in the patients who are already on biologic therapies or who are immunocompromised. We should educate them about the risk of squamous cell carcinoma at their initiation of the treatment. We should always do detailed physical examination on each follow-up. And there is a need for multidisciplinary approach for managing these kind of cases. Patients should be encouraged for self-skin examination, and he should be educated for prompt reporting of any new or changing lesions. Thank you.
So now we shall move on to our next case, which is presented by Dr. Gauhar. She is also teaching widely, which makes both of them as the year one resident in dermatology.
Assalamualaikum everyone. I'm Dr. Gauhar, PG Year 3 in the Department of Dermatology, and I present the second case of this CPC. So the patient was a 14 years old boy, resident of Karachi, who presented to us in dermatology clinic in May 2023 with complaints of thickening and darkening of the neck and axillae for 2 years. There was also a history of hyperpigmented papules and plaques which were present over the upper and lower trunk. According to the patient, he was all right 2 years ago, and then he started to develop symmetric, slowly progressive skin eruptions. Initially, they were grayish, velvety hyperkeratotic plaques on the neck and axillae. In the past 8 months on presentation, he developed patches on central area of the trunk, upper back, abdomen, and chest folds as well. The lesions were associated with mild itching. There were no systemic symptoms, however. Past medical and surgical history was unremarkable. There was a history of seasonal allergies, and for this skin condition, he had taken treatment in Sakhar by another doctor and was given a topical compound prepared at a local pharmacy. Personal and socioeconomic history. He belonged to a middle-class family. There were no addictions. He was a student of O-levels, and there was a significant impact of disease on his psychological well-being and quality of life. Family history was positive for psoriasis. There were no other skin diseases in the family, and there was also a positive family history for diabetes and hypertension. There were no history of thyroid disease or asthma in the family. Parents had consanguineous marriage, and there were such marriages over many generations in the family. On clinical examination, on journal physical examination, it was unremarkable. However, the weight was 95 kgs and the BMI was 30.7, which was consistent with obesity. Systemic examination was unremarkable except that we found gynecomastia. On dermatological examination, the patient was visibly obese. There were hyperpigmented papules and plaques with mild scaling present on the central chest, converging toward the center and also extending to the inframammary areas. Papules and macules at the periphery of the involved skin had a net-like shape. There were also papillomatous plaques on the front and sides of the abdomen, and there was stria seen on the whole body. There was darkening and thickening of skin of axillae, neck, and groin. On examination, the scalp, nails, and mucous membranes were normal. So based on our history and examination, we came up with the following differential diagnosis. Our topmost differential diagnosis was confluent and reticulated papillomatosis. Other differential diagnoses were acanthosis nigricans, Darrier disease, Dowlett-Tico's disease, pityriasis versicolor, dermatitis neglecta, terraperiforme dermatitis, and prurigo pigmentosa. On further dermatological examination, Wood's lamp was negative for any fluorescence. There was no change upon cleaning the plaques with alcohol strips or rubbing them with 70% alcohol swabbing. Hence, we ruled out dermatitis neglecta and terraperiforme. On workup, CBC was within normal range, fasting blood sugar was normal, HbA1c was 6.4, consistent with pre-diabetes, fasting insulin level was raised, indicating insulin resistance, ALT was deranged, which was around 198, AST was also raised, lipid profile was normal, fungus scraping for KOH was negative, IG levels were raised, which were 480. Skin biopsy was done and sent for H&E. Biopsy showed hyper and parakeratosis, acanthosis, and papillomatosis. Granular layer was prominent. In the papillary dermis, there was fibrosis and thin capillaries with mild lymphocytic infiltrate around the blood vessels. PASD was negative for fungal organisms. So based on the clinicopathological correlation, we came up with the diagnosis of confluent and reticulated papillomatosis. CARP is known to be associated with metabolic syndrome and insulin resistance. A multidisciplinary approach in his treatment was taken, and he was referred to gastroenterology and endocrinology teams as well. So from dermatology side, he was started on minocycline 100 mg BID for 6 weeks. Montelukast 10 mg was given for raised IgE levels. Fexofenadine was added PRN for itching. and topical vitamin D analog along with urea-containing moisturizing lotion was prescribed. Patient was counseled regarding need for weight reduction. In further management, he was referred to endocrinologist for management of prediabetes, obesity, and gynecomastia. He was referred to gastroenterologist for management of deranged LFTs after his hepatitis B and C workup came out to be negative on serology, and ultrasound abdomen showed gross fatty infiltration of liver. Endocrinology carried out OGTT, which was again borderline impaired, consistent with prediabetes. His TSH and AM cortisol levels were within normal range. Patient was counseled again about need for weight reduction, dietary and lifestyle modification. He was planned for GLP-1 analog at this point, but it was deferred due to affordability. Gastroenterology diagnosed him as non-alcoholic steatohepatitis. He was again counseled regarding weight reduction, dietary and lifestyle modification. Capsule Evion and Urso were added as a part of management. So on follow-up after 4 weeks, the disease was static on minocycline. The patient was then switched to oral fluconazole 150 mg once a week for 1 month, and then he was followed up again after 1 month. He was advised follow-up after 1 month. However, the patient was lost to follow-up and presented again after 11 months with progression of disease. At this point, his weight was almost static. His ALT had, however, reduced to 153 because he had started treatment of fatty liver. On inquiry, it was found out that the patient had taken fluconazole for 1 month but was non-compliant to lifestyle modification. There was progression of disease and there were newer lesions on the knees, elbows, and lower limb as well. Now, at this point, on the differential diagnosis of CARP and psoriasis, a rebiopsy was done. Rest of the treatment was continued. Histopathology came out to be same as the previous one, again suggesting CARP as the most likely diagnosis. So as there was no response to treatment, he was planned for isotretinoin. Again, he was counseled for weight reduction. A repeat CBC, LFT, and fasting lipid profile was ordered. Rest of the treatment was continued. However, he was lost to follow-up again and presented with further worsening of skin condition after 5 months. There was extensive involvement of trunk and limbs. There was symmetrical hyperkeratotic papillomatous plaques and papules. There were newer lesions on arms and legs and hyperpigmentation of the antecubital foci as well. The lesions were geographic and had a reticulate pattern. Patient was counseled regarding need for weight reduction and need for improvement in his LFTs. His ALT on this visit was 96. However, since this was grade 1 ALT derangement and the LFT trend was going downwards in this patient, he was started on oral isotretinoin 20 mg BID. A repeat test after 1.5 months was advised on follow-up. In November 2024, 6 weeks post-treatment with isotretinoin, he presented with partial resolution of lesions on trunk, arms, and neck. The velvety lesions of axilla, groin, knees, and antecubital foci were, however, and elbows were, however, static. His ALT had improved to 83 with a normal fasting lipid profile. There was a weight loss of 2.5 kgs and a reduction in abdominal circumference by 2 inches. Isotretinoin was continued and he was advised another follow-up after 6 weeks. These are the pictures 6 weeks post-treatment. There was a significant clearance of the lesions on the back, front, and to some degree on the arms as well. However, the acanthosis and velvety plaques remained static. Some more pictures of this patient showing the static acanthotic lesions, the axilla, static lesions of the knees, and to some degree there was improvement on the lesions on the arms as well. This is the comparison before and after of the lesions on the back. You can see there was extensive hyperkeratotic plaques, and then there was significant improvement in the post-treatment pictures. Another comparison of the lesions on the front showing significant improvement. To summarize my case, a 14 years old obese boy presented to us with velvety hyperkeratotic plaques on neck, axillae, groin, and abdomen for 2 years. He had insulin resistance and fatty liver on workup. He was diagnosed and managed as carb with minocycline and fluconazole but did not respond. And then he was started on isotretinoin after improvement in the liver function test. 6 weeks post-treatment, there was partial response, and we took a multidisciplinary approach emphasizing weight reduction and correction of metabolic derangements in this patient. So now moving to discussion and literature review. So CARB is an uncommon disorder of epidermal keratinization. There are hyperkeratotic papules which coalesce into confluent and reticulated plaques. The typical sites are neck, upper trunk, and axillae. The usual age of onset is teenage years. The exact etiology is unknown. However, there are certain hypotheses, including that this could be due to an inflammatory response due to yeast or actinomycete or ultraviolet light. Some cases have reported familial association and abnormal keratinocyte differentiation in CAR, and it's also associated with obesity, metabolic syndrome, Cushing's, thyroid dysfunction, and acanthosis nigricans in literature. The disease has a chronic course with chances of recurrence after treatment. However, spontaneous resolution has been reported and weight reduction helps. There's no systemic involvement in the disease, and usual treatment options include oral and topical antibiotics, oral and topical antifungals, oral and topical retinoids, and topical vitamin D analogs. The case was challenging because there was involvement of unusual sites leading to a diagnostic dilemma. There was resistance to treatment, metabolic derangements, and fatty liver presented another challenge because due to the raised ALT levels, it was difficult to manage initially with isotretinoin. There was a loss to follow-up and non-compliance and lack of lifestyle modifications on the part of patient as well. So now coming to the literature review. So we found a few cases in which there were involvement of unusual sites as presented in our patient as well. So this is a case in which a 15 years old patient presented to them and was diagnosed as CARB, and she had lesions on her knees and elbows since the age of 4 years old. So this also tells that CARB, even though the usual age of presentation is during teenage, can present and begin as early as 4 years old because this patient developed lesions at that age and at the age of 15 was diagnosed as CARB. These are the lesions of knees and elbows similar to our patient. Now another case report of a 12 years old girl who had lesions involving face, neck, middle of the chest, abdomen, upper extremities, elbows, lower extremities, and knees, similar to our case. And the skin biopsy of this patient showed papillomatosis, hyperkeratosis, acanthosis, and hypergranulosis, similar to the biopsy findings of our patient. Now, according to our textbook Rooks, it is mentioned that in CARB, the granular layer is almost diminished or it disappears. But however, our case had hypergranulosis, and this another patient who was diagnosed as CARB and was managed as CARB and responded to treatment also had hypergranulosis on biopsy. So these were the knee involvement in this patient. Now another case in which confluent and reticulated papillomatosis was associated with concurrent acanthosis nigricans, obesity, and insulin resistance, and this patient did not respond to antifungal treatment and did respond to oral retinoid therapy. And another case in which the patient had obesity and PCOS who did not respond to antifungals or antibiotics, however, responded to bariatric surgery. There was a resolution of lesions. So it reinforces the idea that insulin resistor is a contributor to the pathogenesis of CARB. Now, we also looked up that since our patient had raised IgE levels, if there was any association of atopy or raised IgE levels with CARB. So we found a series of two cases in patients who had atopic symptoms and raised Ig levels who also had CAR. The last article that I'm going to talk about is about treatment outcomes in confluent and reticulated papillomatosis, a systemic review. This discusses different treatment options, the number of times they have been reported in literature, and whether there was resolution, no resolution, partial resolution, or complete resolution, and the duration in which that resolution was achieved. This was a comparison study. So it talks about the antibiotics, antifungals, and retinoid therapy. So for oral isotretinoin in CAR, 6 cases were reported, of which 1 had no resolution, 1 had partial resolution, and 4 cases had complete resolution. An average duration in which resolution was achieved was 150 days. So the take-home message is treatment of metabolic derangements and weight reduction is an essential part of management of CAR. There can be unusual presentations that can lead to diagnostic challenges. So multidisciplinary approach should be taken to optimize the management in such patients. Thank you very much. My references are Root's Textbook of Dermatology, PubMed, and UpToDate. Thank you.
So we shall now move on to our last case, and our senior resident, Dr. Shahban, is going to present the third case.
Assalamu alaikum, everyone. My name is Dr. Shahar Bano. I am resident dermatology here at Aga Khan Hospital. So the outline of my presentation is as flashed. 60 years old male, resident of Karachi, known case of hypertension, follicular B-cell lymphoma, presented with complaint of fever, body aches, painful pustular lesions in the scrotal and inguinal area for 3 days. Past medical history includes B-cell lymphoma stage 4, for which 6 sessions of chemotherapy with rituximab and R-Venda were done 3 months back, and hypertension. Patient denies a history of skin disease. Drug history include tablet amlodipine 5 mg QD, and patient belongs to upper middle class. On general physical examination, patient's vital showed blood pressure of 130/70. His pulse was regular, 104 beats per minute. Respiratory rate was 18 breaths per minute, and patient was afebrile. On general physical examination, patient had bilateral inguinal lymphadenopathy, and he was pale. Systemic examination was unremarkable. Lab workup showed hemoglobin of 8.3, TLC count was consistent 0.4, and platelet count was 154. His creatinine and LFTs were within normal limits. So on dermatological examination, there were multiple vesicles and pustules which were seen on the scrotum and inguinal region, few encrusting and surrounding erythema. Patient was treated on line of herpes genitalis HSV2 with acyclovir 400 mg TID for 3 weeks. Mucor ointment twice a day was advised for topical application on affected areas. ID was taken on board and suggested for 3 weeks of acyclovir due to immunocompromised status of patient. Pain resolved, lesions healed, but one lesion increased in size and became calcified. Few new lesions ulcerated and increased in size. Meanwhile, ultrasonography of inguinal area was carried out to see soft tissue pathologies which showed no focal calcification or abscess. During this course of time, new ulcerated plaques developed in bilateral inguinal folds, the same sites of follicular lymphoma and scrotal area, which were increasing in size and number. A multidisciplinary team was treating the patient here, which was comprised of dermatologist, oncologist, internist, and infectious disease specialist, and they advised to go for incisional biopsy. So the pictures on the left are showing the inguinal ulcerated plaques and nodules, and on the left side of scrotal ulcerations. So based on the history and clinical examination, our differential diagnoses were deep mycosis, ecthyma gangrenosum, lupus vulgaris, pyoderma gangrenosum, and cutaneous metastasis. Biopsy from the inguinal and scrotal lesions revealed inconclusive results. So deeper cuts were requested for the establishment of a definitive diagnosis. Meanwhile, multidisciplinary team agreed to start tablet augmentin 1 gram BID till the report of biopsy. They advised to avoid strong antibiotics due to suspicion of lupus vulgaris. So after starting augmentin, pain settled with resulting suppuration in the lesions. Biopsy of the deeper cuts revealed epidermal ulcerations, dermal edema, and neutrophilic infiltrate, which was consistent with the diagnosis of pyoderma gangrenosum. So our final diagnosis was genital pyoderma gangrenosum. We managed the patient with intralesional corticosteroid injection, oral ciprofloxacin 500 mg BID for 5 days, clindamycin 600 mg TID for 7 days, along with IV immunoglobulins 10 gram to boost the patient's immunity and IV rituximab 1 gram. We also emphasized on local hygiene and sterile dressings. So this is the pictorial depiction of the patient before treatment and after treatment. Now coming towards the discussion. Pyoderma gangrenosum is a rare, non-infectious, autoinflammatory neutrophilic dermatosis. Diagnosis is based on clinical features and exclusion of other cutaneous ulcerating disease. Associated conditions with this are inflammatory bowel disease, rheumatoid arthritis, seronegative arthritis, hematological malignancies, and visceral malignancies. Its pathophysiology is complex and multifactorial. Pathology is a phenomena whereby skin trauma provokes lesions or first onset of disease at the site of injury. A cascade of inflammatory events, activation of innate immunity, neutrophil activation, recruitment of adaptive immune response, and tissue destruction occurs. So there are various types of pyoderma gangrenosum, and we'll be discussing each of them one by one. So classic ulcerative PG is the most common type. It presents as small, tender, red, blue papule, plaque, or pustule. It evolves into painful ulcers with violaceous undermined edges with granulation tissue at the ulcer base. It most commonly involves legs around 70%, and it very rarely involves genitals and mucosa. Healing occurs with atrophic cribriform scar. There are associated symptoms like fever, malaise, myalgias, and arthralgias. Pustular pyoderma gangrenosum is a variant often occurring during acute exacerbation of inflammatory bowel disease. Discrete painful pustules with a surrounding halo of redness develop on normal skin. Parastromal pyoderma gangrenosum arise as a pathologic response to trauma of stoma formation and fecal irritation, most common with ileostomy for active inflammatory bowel disease. Risk is greater with high BMI, female sex, and autoimmune disorder. Granulomatous superficial PG is a variant with superficial lesions showing a granulomatous histology. It begins as a single superficial ulcer with granulation and elevated edge. Bullous pyoderma gangrenosum presents with rapidly arising superficial hemorrhagic bulla, commonly located on arms. Typically ulcerates and heal with scarring. It is associated with myeloproliferative disorders and hematological malignancy. So differentials are usually vascular occlusive or venous disease, vasculitis, primary infection, drug-induced tissue injury, atypical mycobacterial infection, sporotrichosis, deep mycosis, and mycosis fungoides. Investigations that are carried for pyoderma gangrenosum. Actually, it is a diagnosis of exclusion. However, clinical evaluation, skin biopsy, tissue culture for bacterial, atypical, mycobacterial, fungal, and viral pathogens to rule out other causes is done. A thorough workup should be conducted to rule out any underlying systemic disease. The basic principle of management is induction of remission and analgesia, along with maintenance of remission and wound healing. So first line is always topical and intralesional steroids, topical tacrolimus. Second line involves corticosteroids, cyclosporin, methotrexate, mycophenolate mofetil, and dapsone. Third line is anti-TNF agents, including infliximab, adalimumab, etanercept. Other biologics that can be used are ustekinumab, guselkumab, anakinra, canakinumab, and IV immunoglobulins can also be administered. Now, moving towards the literature review. A case report was published in Curious in 2024 of a 75-year-old male with diffuse large B-cell lymphoma who presented with painful ulcerated plaques on dorsum of bilateral feet. And upon biopsy, it was consistent with pyoderma gangrenosum, and patient was successfully treated with topical steroids and tacrolimus. Pyoderma gangrenosum can rarely present in genital, anal, and perineal regions, and two such cases were reported in Journal of ASTDA in 2024. Another case was reported in JAD in 2018 of a 64 years old woman with follicular lymphoma in partial remission who had severe genital pyoderma gangrenosum, and she was successfully treated with cyclosporin low dose. So take-home message is a detailed clinical history including underlying systemic conditions such as malignancies can guide the accurate diagnosis. A multidisciplinary approach in such cases with collaboration of hematologists, pathologists, and other specialists is essential for both diagnosing and managing complex cases effectively. Holistic care should be done addressing the underlying systemic disease such as follicular lymphoma and associated infection in this case is crucial for optimal treatment outcomes. So we should treat every case as a new challenge. Simple diagnoses also need our attention and comprehensive care. Thank you.
So now the floor is open for discussion, questions, comments. So kindly you can raise hand or you can write in the chat box so we can unmute you. Any questions and comments, you can write in the chat box. Whoever wants to comment or ask a question, so then we shall unmute.
Like Myra from Civil Hospital. Can you hear me?
Yes, we can hear you.
Okay, first of all, I must congratulate Dr. Sadia Tabassum, Dr. Sadia Masood, and Dr. Shaheen and their team from AKU department for their excellent presentation and management of these cases. And everyone from all over, no, from all over Sindh, they can come across such type of cases. And the objective of this CPC is to share your clinical case with others. This is how we can present our cases and we can share our cases with others. So I would invite others also from the Sindh, like Dr. Bashir from Civil Hospital, Hyderabad, Dr. Maria, Dr. Irfan Sheikh, so that they should also come up with their cases and they should present in this CPC. Thank you.
जी अस्सलाम वालेकुम
वालेकुम अस्सलाम।
आवाज आ रही है
जी जी बिल्कुल आ रही है
जी Dr. Sadia, I am so pleased to have listened to this presentation and congratulations to all of you, your team, Dr. Sadia Masood, Dr. Shaheen and everyone. And we are really glad that today was my first winter holiday, but I've had this 1 hour of very fruitful learning. And I'm sure this will be a motivating point for all of us, especially us to present such cases and take part in these CPCs. And I've encouraged my PGs as well, because this was an excellent presentation by your PGs, and I'm so glad that the follow-up was there and the references were there, which were very useful for us. And in the first case, I was also thinking of the first differential as PG, but obviously it turned out to be SCC, and it was so like eye-opening that we keep on giving biologics time and again, and we've started, all of us have started using them, but sometimes the follow-up is not all that vigilant, which it should be. So thank you so much. And once again, I think we are really happy to have this academic activity from your side. Okay, take care. Thank you.
Thank you. So any other questions or comments? We are open. So I think we have Madam Yasmina with us if she wants to make some comments or ask any questions.
Can you hear me?
जी मैडम जी जी अस्सलाम वालेकुम
Walaikum salam, doctor. I'm very much impressed and very happy to hear the three cases presented very well. And I hope and pray that you will continue your academic activity
जी जी
because
इंशाल्लाह.
for the inshallah for the next year from January till July the aesthetic cases aesthetic presentations have been all fixed from January to July. So I would very much appreciate if even the academic presentations are
Yes,
done.
definitely we shall continue with the academics simultaneously. Definitely.
That's what my wish is.
And thank you so much for joining this meeting and
Uh,
attending our cases.
no, yeah, I always enjoy academic activity, and I always used to visit the places in Karachi, but now I'm a bit too senior to move about, so I like to listen at home. So thank you very much, and please continue your good activity.
Thank you so much for your
Thank
time and attention.
Welcome, welcome.
We don't have any other questions or comments. I would like Dr. Shaheen to make some comments on our behalf. Assalamu alaikum, everyone. Thank you so much, everyone, for joining us today. And I really appreciate and thanks all for appreciating our efforts. So our team really worked hard for this. Like our pages did work for this APC for they are working for the last 2 weeks to get the literature review and everything. So I must thank you, our pages at this forum today. And thank you all again for joining and appreciating our cases. Thank you. So I would now ask Dr. Sadia to also make some comments on how we prepared and we have been doing it for the past 2 to 3 years now.
Thank you, everyone. I think it was nicely presented by our resident, and thank you all of you who joined us today. We just try to continue such activities, and in the past, I think we have been doing for the past 2 to 3 years regularly. And it's always good to see all the residents who are presenting and the one who are attending and learning from such activities. So हाँ, I think हमने 3 years हो गए हैं कि हम करें. Dr. Humaira started this idea and everything, and then every hospital in Karachi is doing. So I really like the idea कि interior sin या I must say कि across Pakistan सब लोगों को involve होना चाहिए. It's not just learning for resident, it's learning for us. हमारे लिए भी learning है. Like this is the simple case. The third one was my case of pyoderma gangrenosum. And we were just हम बहुत we were just worried about the case. It was just simple. If anybody was thinking कि ये बहुत simple pyoderma gangrenosum है, but for me it was not just simple pyoderma gangrenosum because patient follicular lymphoma था. हमें oncologist they were pushing us to treat. ID were pushing us not to give any antibiotic. वो कह रहे हैं steroid नहीं देना, antibiotic नहीं देना. It could go into the lupus vulgaris or something. But my team is evident that how we struggle for this case. हमने इतना उसके लिए struggle किया. We talked to different dermatologists, we talked to oncologists, plastic surgeon, ID, everyone. But at the end, alhamdulillah, you can see the difference कि patient finally ठीक हो गया. उसकी immunity boost करने के लिए we give immunoglobulin दिया, उसको retux, उसकी disease process को stop करने के लिए दिया, and finally the end result is good. So whenever you put your heart, your brain in your cases, you will see the result. So the take home message for all the resident कि आप लोग अपने मरीज को ओन करें और ये इस तरह के जो लर्निंग फोरम्स है just try to attend. This is the good learning opportunity. हम एक दूसरे के एक्सपीरियंस से लर्न करते हैं. It's not just कि आप लोग लर्न करते हैं, हम भी लर्न करते हैं. So thank you all of you who attended this academic activity, and I'm sure we would continue, and the more institute would participate in this activity. Thank you very much.
So thank you everyone for joining us today, and I hope everybody learned, and thank you to our own team who have worked very hard for these cases. So we shall conclude now and wish all of you season's greetings and a happy new year. Allah Hafiz.